Hello everyone. Now continuing the discussion on ECGs. First of all, we read about the rate calculation, then the axis determination, and then we have discussed about the P wave and the Q wave. Now, in this lecture, we will be discussing about the rest of the waves in the ECGs. Now, starting with the R wave. R wave, as I have already told you, R wave is the first positive wave in the QRS complex. It is the first positive wave in the QRS complex. Before going into abnormalities of the RV, let us first clear some of the concepts. If you see, this is the schematic representation of the heart, and these are the lead placements: V1, V2, V3, V4, V5, V6. You must be knowing that V1 and V2 are called the right-sided leads. V3 and V4 are called the septal leads, and V5 and V6 are the lateral leads. Lateral leads. Okay. Now, what I wanted you to know is the action potential that starts from the SA node comes to the AV node. From here, bundle of his, then the right bundle, then right bundle and left bundle, and then through the Purkinje fibers, it supplies the ventricles. Supplies the ventricles. Now, I have already told you that action potential from the AV node, it will go to the bundle of his, and then first it will enter the left bundle branch. Okay, sorry, the left bundle. First of all, it will depolarize the left bundle followed by the right bundle. That's why the depolarization of the septum happens from left to right. So depolarization of the septum happens like this from left to right. Okay. Then what happens? Then the action potential goes through the Purkinje fibers into the ventricles. Remember, both the ventricles will be depolarized at the same time because the Purkinje fibers will go and supply the all the ventricles, both right and left ventricle at the same time. So action potential will be provided to both right and left ventricle at the same time in a normally functioning heart. So the ventricles will be depolarized at the same time, and both right and left ventricle will contract at the same time. Okay. So if they contract at the same time, because the left ventricle has a larger mass, it will drag the vector towards it. So the net ventricular depolarization vector will be towards the left side because the left ventricle is much more larger and dominant among the two ventricles. So after the septal depolarization, the net ventricular depolarization vector will be like this. Will be something like this, or maybe a little bit more towards the left. Little bit more towards the left. Okay. So if you represent these events diagrammatically, this will produce the QRS complex, classically QRS complex. So what will happen in V1? In V1, what will happen? In V1, the septal depolarization is occurring towards V1. Okay, so this septal depolarization here, this is occurring towards the V1. That means it will produce a positive deflection in the V1. So this is the septal depolarization, the positive deflection. It will be followed by the ventricular depolarization, which is in the opposite direction of the V1. Okay, it is in the opposite direction of the V1. So it will produce a negative wave up to that. So like this, something like this. So this will be small r, capital S, like this, small r, capital S. I have already told you the first positive wave is R. If R is smaller in amplitude, you have to represent it with small r, and then the S wave. S wave represents to the ventricular depolarization, the net ventricular depolarization, which is happening in the opposite direction of the V1. Similarly, if you go to the other spectrum, what will happen in the V5, V6? In V5, V6, the septal depolarization is happening in the opposite direction of the V5, V6. So the septal depolarization will be represented by the small negative wave, followed by a larger positive wave, that is the net ventricular depolarization, which is happening towards the V5, V6. So it will be like this. So V1, in V1, we are finding something like this. In V6 or V5 or V6, we are finding something like this. Now, what will happen in the in-between leads? In the in-between leads, the R, you can see in the V1 the R is very small, but you can see in the V6 the R is very large. Similarly, what will happen? Gradually from V1 to V6, the amplitude of the R wave will increase. Okay, the amplitude of R wave will increase, and the amplitude of the S wave will gradually reduce. Okay, the depth of the S wave will gradually reduce. So V1, V2, V3, V4, and V5, something like this. Okay. So what you can see here, the R wave amplitude is gradually increasing from V1 to V6. R wave amplitude is gradually increasing from V1 to V6. Now this is known as R wave progression. R wave progression, or the normal R wave progression. Okay, this is known as R wave progression. After this much of basics, now we'll see what are the abnormalities that will happen with regards to R wave. Okay. Now the first abnormality that we should know is dominant R wave in V1. As I have already told you, and you have understood from this image, that R wave has to be very small in V1. As in this image, R wave has to be very small in V1. Okay. So if you are getting a dominant R in V1, that means it is pathological, it is abnormal. Now, in which conditions you will get a dominant R in V1? In which condition you will get a dominant R in V1? So dominant R in V1. So dominant R in V1. What are the conditions you will get dominant R in V1? Remember, if in this image, if in this image, right ventricle is much more powerful than the left ventricle, right ventricle is more powerful than the left ventricle, then the net ventricular depolation vector will be towards the right side, as opposed to the normal heart. If the right ventricular mass is much more and it is the dominant ventricle among the two ventricles, net ventricular depolation vector will be towards the right side. If the net ventricular depolation vector is towards the right side, then what will happen in V1? In V1, first of all, what will happen? There will be septal depolation. Septal depolation, I told, it is happening from left to right, so of course it will produce a positive wave. Then comes the ventricular depolation vector, and again the ventricular depolation is happening towards the V1. So again it will produce a predominant positive wave followed by the negative, small negative wave. Okay. So as you can see here, the dominant R is happening because of the right ventricular hypertrophy. So the first example is right ventricular hypertrophy, where you will get a dominant R in V1. Okay, right ventricular hypertrophy can occur due to so many causes. It can occur due to pulmonary stenosis. It can occur due to pulmonary regurgitation. It can occur due to pulmonary hypertension. There are so many causes. Now, the second cause is right bundle branch block. Right bundle branch block. Now, how right bundle branch block will produce a dominant R in V1? So that will be understanding here. So again, we'll repeat the same image. The AV node, then the bundle of his, then the right bundle, then the left bundle. Now, what is happening here? The right bundle, here there is a right bundle branch block, RBBB, right bundle branch block. So, what will happen? This bundle branch is not functioning. This is not functioning. So, what will happen now? Action potential will come from the AV node. It will come from, start from the AV node, then through the bundle of his, it will go to the left bundle branch. It will go to the left bundle branch. Then it will supply the left ventricle. It will supply the action potential to the left ventricle. But now here the right bundle branch is not functioning. Right bundle branch is not functioning. So what will happen? How the right ventricle will contract? Now right ventricle will contract by deriving the action potential from the left ventricle. So there will be intramyocyte transfer of the action potential from the left ventricle to the right ventricle, and the right ventricle will contract. But remember, this myocyte conduction of the action potential is very slow compared to the Purkinje fibers. Okay, so myocyte action potential conduction is very slow compared to the Purkinje fiber conduction. That's why right ventricle will be depolarized distinctly after the left ventricle. So whenever there is a right bundle branch block, first of all there will be septal depolarization, no doubt in that. Septal depolarization. It will be followed by left ventricular contraction. It will be followed by left ventricular contraction. This will be followed by a right ventricular contraction, but this right ventricular contraction will be a delayed one. It will be a delayed one because the action potentials are being conducted through the myocytes. So the process will be slow, and the vector that will be produced in the ECG will be a delayed one. Will be a delayed one. That means this will be represented by a wide QRS complex. This will be represented by a wide QRS complex because here the conduction is happening slowly and the contraction is happening slowly, or the depolarization of the right ventricle is happening slowly, and that will be represented in the ECG as a wide QRS complex. Now we'll see how it will be seen in the V1, lead V1 and in the V6. This is V1 here, this is V6 here. So the first event I told is the septal depolation. First event is septal depolation. Septal depolation is happening from the left to right, like a normal heart. So it will be so it will produce a positive wave in V1. It will produce positive wave in V1. Then what happens? Then there will be left ventricular contraction. So left ventricular depolation. So left ventricular depolation is happening like this. That is opposite to V1. So it will produce a negative wave. It will produce a negative wave. Then there will be right ventricular contraction. There will be right ventricular contraction which will produce a vector like this. And I told right ventricular contractions will be slightly delayed. So again, this right ventricular contraction which is happening distinctly from the left ventricle. In the previous, like in a normal heart, what I told that both right and left ventricle will contract simultaneously because Purkinje fibers are supplying both the ventricles and they will conduct the impulse at the same time. But in right bundle branch block, the right ventricular contraction will be delayed than the left ventricle because here the conduction is happening from the left ventricle myocyte to the right ventricle myocyte. So here the contractions are separated. Okay, so the first positive wave I told it is because of the septal depolarization. Then there will be a negative wave due to left ventricular contraction, and then it will be followed by a right ventricular contraction. Right ventricular contraction will produce the vectors towards the V1. It will produce vector towards the V1. So again there will be a big positive wave because I told it is delayed. It will be the right ventricular contraction is delayed. So it will produce a big or delayed positive wave. So something like this. Okay. So this is the V1 in case of right bundle branch block. So what will happen in V6? V6, the septal depolation produces small negative waves. Then there will be left ventricular contraction, which will produce a positive wave. Then there will be right ventricular contraction, which will again produce a negative wave. Again produce a negative wave. Because the right ventricular contraction vector is in the opposite side of V1, V6, so it will produce a negative wave. So something like this. Okay. So as you can appreciate here, in V1 it is M, and in V6 it is W. In V1 it is M, in V6 it is W. Sometimes in V1 it is known as R, S, R dash, R, S, R dash, because small r is the first positive wave, then the negative wave is S, then the third positive wave is R dash. The positive wave that follows S is known as R dash. Okay. So in V1 we are getting M, and in V6 we are getting W. So the mnemonic you can remember is marrow. What is marrow? Marrow means in right bundle branch block R. So RBBB in right bundle branch block. In V1 you will get M pattern. In V6 you will get a W pattern. Okay. And from this you can understand that it will have a dominant R in V1. Dominant R in V1. Okay. Now what happens in LBBB? What happens in left bundle branch block? In left bundle branch block, the exactly opposite phenomenon will happen. I will not be discussing that it again here. What will happen in left bundle branch block? From the concept of right bundle branch block, you can also derive what will happen in left bundle branch block. Anyway, I'll be discussing all these things again in the bundle branch block section. As of now, you remember that exactly opposite thing will happen in left bundle branch block. That is W pattern in V1 and M pattern in V6. So the mnemonic is William. That means in case of LBBB, W pattern will happen in V1 and M pattern will happen in V6. Okay. So these are the concepts of bundle branch block, marrow and William. And one more important point is wide QRS complex, because here the conduction is delayed. The net vector will have a wider complex. Okay. So wide QRS complex is a feature of bundle branch blocks. Remember this exactly same pattern with exactly same pattern, but QRS complex being normal. Okay, the pattern will be M and W, but the QRS complex is of normal duration. Here I must tell that the normal QRS duration is 120 to 200 milliseconds. Sorry. The normal QRS duration is up to 120 milliseconds, usually 80 to 120 milliseconds, or three small boxes. The normal QRS duration is 120 milliseconds or three small boxes. Okay. So wide QRS means it is definitely more than 120 milliseconds or three small boxes. Okay. So sometimes a situation may arise where we will get a pattern like this. That means M pattern in V1, W pattern in V6, but the QRS complex is normal or narrow. Now in that situation is called as incomplete bundle branch block, incomplete RBBB. Okay. So bundle branch block means there has to be wide QRS. If wide QRS is not there, but pattern is compatible with bundle branch block, that is known as incomplete bundle branch block. And we will be discussing more on this in the bundle branch block section. So I have described how RVH will produce a bundle branch block, then how RBBB will produce a bundle branch block. How RVH is producing a dominant R in V1 and how RBBB is producing a dominant R in V1. Now, what are the other conditions? Other conditions include WPW, WPW type A. Now, what will happen in WPW? How WPW is producing a dominant R in V1? So again, I'll go to the previous image. Uh, no space left here. Well, I'll be showing here. So what happens in WPW? In WPW, there is a connection between the atrium and the ventricle, which is not AV node. That means normally what happens, this is the SA node, this is the AV node. Axial potential comes from the SA node to the AV node through internodal fibers. Then from bundle of is right bundle branch, left bundle branch to the Purkinje fibers. What happens in WPW? In WPW, there is a connection here. There is a connection here, or maybe somewhere, which is causing a propagation of axial potential from atrium to the ventricle, bypassing the AV node. Okay, so this pathway in WPW known as bundle of Kent is known as bundle of Kent. Through this bundle of Kent, axial potential will come from the atrium to the ventricles directly bypassing the AV node. So from this you can understand that the AV nodal delay, the characteristic AV nodal delay that happens during in a normal ECG strip that is represented in the PR interval, PR segment, I must say, the PR segment in the ECG, which is the isoelectric line, that represents the normal AV nodal conduction delay. Now that thing will not happen in case of WPW because there is a pathway which is bypassing the AV node, and this pathway will not have not cause any conduction delay. Now how it will be represented in the ECG? So ECG, there will be, first of all, there will be atrial depolarization, that is a P wave. Okay, then there is no delay. That means P will be followed directly by the QRS. There will be no PR segment because AV node is not involved. Okay, so immediately after the P wave, there will be origin of the QRS complex. Now remember here, if the pathway is on the left side, as I have shown here, this is known as type A WPW. Type A WPW. Because the pathway is on the left side. If the pathway is on the right side, that is known as type B WPW. We are discussing type A WPW. Now what will happen here? Now the action potential from after the atrial depolarization, after the P wave, action potential directly comes to the ventricles. First of all, it will stimulate the left ventricle because it is connecting the left ventricle. Now left ventricle will be stimulated and it will cause left ventricular contraction. So the net vector of for the ventricular depolarization again will be towards the left side because left ventricle is prominent. But what is important here, that again here the conduction from ventricle to ventricle is happening through the myocytes. Here again Purkinje fibers are not involved. The ventricular action potential propagation is happening through the myocytes. So that's why the QRS complex will be delayed. The QRS complex will be delayed because the propagation of action potential will be slowed. So it will have a wide QRS complex. Now one more thing is delta wave. Delta wave is the initial slurring that you may see here, initial slurring, it is slightly exaggerated, but the initial slurring is seen because there is a sudden loss of action potential from the atrium to the ventricle. So there will be initial, you can say, sudden depolarization of some of the ventricular myocytes here. Sudden depolarization of the ventricular myocytes here will produce a initial slurring. Initial slurring in the upstroke of the R wave. So that is known as the delta wave. And there will be wide QRS because the whole ventricle, both the ventricles are getting activated through the myocytes and not through the Purkinje fibers. So these are the 3 points related to. Uh, these are the 3 points related to WPW type A or WPW in general. Okay, so as you can see here, the 3 points are absent PR. So PR interval will be absent. Then there will be a delta wave. Then there will be wide QRS. This is tried for WPW. Again, we will be discussing this when we discuss about the WPW syndrome. Okay. Now, in this scenario, what will happen to V1? In this scenario, what will happen to V1? Now, in V1, as you can see here, the left ventricle is getting activated first. The left ventricle is getting activated first. So the vector will be towards. It will be like this. It will be like this. So there will be a first negative wave because of the left ventricle, and then gradually this left ventricular action potential will be going to the right ventricle. So action potential will go from the left ventricle towards the right ventricle. Now this right ventricle will produce its own vectors towards the V1. And I told you, because right ventricle is getting the action potential through the myocytes, the right ventricular action potential will be delayed. Okay, this right ventricular contraction will be delayed, and in the pictorial representation, it will have a wider complex. So sorry, I have again I've forgotten the septal depolarization here. So first of all, it will have a septal depolarization which is towards the V1. Septal depolarization happen towards the V1 again because left ventricle is getting activated first. So the septal depolarization happen from left to right. Okay. So septal depolarization will produce a small positive wave, then the left ventricular depolarization, and it will be followed by the right ventricular depolarization. So again, V1 will produce something like this, which is very much similar to RBPB. Is very much similar to RBBB. I hope it is clear now. I hope it is clear now. As you can see, because there is a connecting pathway from atrium to the ventricle. There is a connecting pathway from atrium to the ventricle. The ventricular myocytes will be activated first. Okay, the ventricular myocytes will be activated first. And inside the ventricle, the first event has to be the septal depolarization, which will produce a positive wave, small positive wave in the V1. This will be followed by left ventricular depolarization because the connection is present on the left side. So left ventricular depolarization will produce a negative wave. Then it will be followed by right ventricular depolarization, which will be slowed. So that will again produce a positive wave in the V1. So the picture is again like M. So this is very much similar to right bundle branch block. So the type A WPW will produce a similar picture like that of a right bundle branch block. And I have told right bundle branch block will have a dominant R in V1. Will have a dominant R in V1. So WPW type A is equivalent to right bundle branch block in terms of the ECG representation, and WPW type B will be similar to left bundle branch block. Okay. So again, similar to RBBB, WPW type A will produce a dominant R in V1. Then sometimes posterior wall MI will produce dominant R in V1. Apart from this hypertrophic cardiomyopathy, as you may be knowing, the small positive wave in the V1 is due to septal depolarization. Okay. Now, in a normal heart, the small positive wave in the V1 is due to septal depolarization. So, if the septum is massively hypertrophied, it may produce a dominant R. Okay, it may produce a dominant R. So, hypertrophic cardiomyopathy can cause a dominant R in V1. Apart from that, sometimes in case of dextrocardia or incorrect lead placement, incorrect lead placement can cause dominant R in V1. Apart from that, a very interesting cause like dystrophies. dystrophy like myotonic dystrophy or Duchenne muscular dystrophy, they can also have a dominant RN. V1, apart from that, it can be a normal variant also. It can be normal variant also. Okay. Now, these are the causes of dominant R in V1, and I hope you understood the concepts why there is a dominant R in V1. So, V1 will never get a dominant R whenever in a normal heart. If you are getting a dominant R, it has to be pathological. You have to look for these changes, look for these abnormalities. Now, the second important concept about ROF we have to remember is of dominant R in AVR. Before that, we'll just see some of the ECGs. As you can see here, we are getting a dominant R in V1. This is definitely not normal. And here the cause is right ventricular hypertrophy. In right ventricular hypertrophy, the ROF will be more than 7 mm, or R by S has to be more than 1. Anyway, this we'll be discussing more when we discuss about the ventricular hypertrophies. Here you can see in V1 there is a M pattern, and in V6 okay, the W pattern is not very prominent here. Anyway, we are getting M pattern or RS pattern in V1. So this is right bundle branch block. You can see dominant R in V1. Okay. Now we'll see the dominant R in AVR. Okay. So dominant R in AVR. Now what happens in AVR? If you remember the AVR, the direction of the AVR is almost exactly opposite to the normal cardiac axis direction. Okay. So if you remember, this is AVF, this is lead 1, this is lead 2, this is lead 3, this is AVL, and this is AVR. And you must be knowing that normal axis of the heart lies like this in the direction of the lead 2, and you can see the direction of the AVR is almost exactly opposite to the normal cardiac axis. Okay. The predominant component of the QRS complex is driven by the net ventricular depolarization, which is happening towards the left ventricle in this axis, in the axis of the lead 2. That is the predominant component of the QRS complex. So, AVR is present exactly opposite to this. That's why the AVR will not have a predominant positive component. Okay? AVR will not have a predominant positive component in a normal heart, because the net vector of the ventricular depolarization is happening in the opposite direction of the AVR. So that's why we'll never get a prominent R in AVR. We'll never get a prominent R wave or prominent positive in AVR. So whenever we are getting a dominant R in AVR, that means there is something abnormal, there is something pathological. Okay, so what can cause? So if there is a dextrocardia, then everything is opposite. So dextrocardia can have a dominant R in AVR, and sometimes wrong lead placement can have wrong lead placement. Anyway, these causes are not really pathological. So really, what are the pathological condition where you get a dominant R in AVR? Very important cause is ventricular tachycardia. Usually the action potential starts from the SA node, then AV node, then the ventricles. But what happens in ventricular tachycardia? The action potential originates from the ventricles. So the net cardiac depolarization is happening from ventricle to atria. The net cardiac depolarization or everything is happening from ventricle to atria. So now this ventricle to atrial or from downwards to upward depolarization is presented in AVR as a positive wave. Okay. So if the action potential is originating here, the net vector direction will be upwards like this. So this is in direction of the AVR. So AVR will have a dominant R wave. So in case of ventricular tachycardia, AVR will have a dominant R wave. Apart from that, a very important cause is sodium channel blocking, poisoning with sodium channel blockers. Blockers. Most important cause is tricyclic antidepressant. Poisoning with tricyclic antidepressant will cause a dominant R in V1 and wide QRS complex like this, something like this. This pattern is very characteristic of tricyclic antidepressant poisoning. You all must be knowing that the treatment for TCA poisoning is soda bicarb. Okay. Treatment is product accurate. Near TCA poisoning, again, we'll be reading in the ECGs of toxicology. So, for the time being, you remember dominant RE in AVR means either it is ventricular tachycardia or TCA poisoning or dextrocardia by wrong lead placement. Coming to the next section of RWF is that is the poor RWF progression. So the third one is poor RWF progression. The poor RWF, before understanding poor RWF progression, you must be knowing what is RWF, normal RWF progression that I have already told you in the beginning of this lecture. This is the normal RWF progression. This is normal RWF progression. But this, if this progression is not happening, that means from V1 to V6, the RWF amplitude is not increasing as expected. So that is known as poor RWF progression. Poor R progression. By definition, if lead V3, in lead V3, the RWF is less than 3 mm. By definition, this is known as the poor RWF progression. In V3, RWF is less than 3 mm. Okay. Now, which conditions will cause poor RWF progression? For all practical purposes, remember, if we are getting in the ECG poor RWF progression, the most important cause you have to remember is myocardial infarction. Maybe acute, subacute, or maybe old. But myocardial infarction is a very important cause of poor RWF progression, and it is of course the anteroseptal. It is of course the anteroseptal MI. Maybe acute, maybe subacute, maybe old. But if we are getting a poor RWF progression, it can be MI. Apart from that, which other causes? Again, those two causes: dextrocardia or wrong dextrocardia or wrong lead placement. These things also can cause a poor RWF progression. As you can see here in this ECG, you can see that lead 1 is completely negative, AVR is completely positive. From this, you can understand that there is some problem with this. Lead 1 has to be positive, lead AVR has to be completely negative. This is what should happen in a normal ECG. If you remember the concept that AVR is exactly opposite of the normal vector propagation. So AVR will always have a negative, everything negative. Lead 1, 2 will have always positive because it is in the direction of the action potential propagation and the depolarization. So if you are getting lead 1 to negative, lead AVR is positive, that means something is wrong. And if you see the from V1 to V6, you can see the RWF progression is not happening. V1, V2, V3, V4, V5, V6. The normal RWF progression is not happening. So this is the diagnosis is dextrocardia. Very similar picture will also get in wrong lead placement. Okay, so this is about the poor RWF progression. Again, this is the ECG of the same dextrocardia where we are getting a poor RWF progression. Now that's all about the R wave. Then we'll go to the T wave. Now T wave is a positive reflection after each QRS complex and will represent ventricular depolarization. This everyone must be knowing. Now T wave abnormalities are also very common and all are aware of it. If you are getting a peak T wave like the peak tented T wave that is characteristically seen in hyperkalemia, but if you are getting a hyperacute T wave, shown in this image, if you are getting a hyperacute T wave just after the QRS complex, you are getting a tall T wave like this hyperacute T wave. This is seen in MI initial phase. Probably the first change in the ECG in case of myocardial infarction is hyperacute T wave. Okay, so before settling of the ST elevation, you may get a hyperacute T wave. Here in this case, they have given as premetal angina. Okay, that also will produce similar kind of ECG changes as MI. So hyperkalemia will produce a tall tented T wave. Here, surface area will not increase. The area under that will not increase, but in case of hyperacute T, the area under the curve will increase. Okay, that is something which you can remember to differentiate between the tall T of hyperkalemia and hyperacute T of MI. Any more on this hyperkalemia changes we'll be discussing later in the electrolyte ECG abnormalities in the electrolyte section. As of now, just remember hyperkalemia, tall T wave. Then inverted T waves. There are so many causes for inverted T wave. Remember, whenever there is uh, whenever there is a ventricular strain, ventricular strains are usually associated with ventricular hypertrophy. So whenever you are getting a ventricular hypertrophy with strain, you will get inverted T waves. Whenever you have bundle branch blocks, you will get inverted T waves. If you remember the previous image of bundle branch block that I have shown you. Yes, as you can see here. So whenever there is a bundle branch block, there is always associated inversion of T wave. Okay, so that also you have to remember. So this can also produce a inverted T. Apart from that, inverted T can be seen in children. You can say neonates. It can be seen as a persistent juvenile pattern. Of course, these are all benign conditions. Juvenile pattern. You can get inverted T waves in NSTMI. Even in MI, like old MI cases, you may get inverted T. Apart from that, you can get in hypokalemia, of course. In hyperkalemia, you will get a tall T. In hypokalemia, you can get a inverted T. You can get inverted T in case of hypertrophic cardiomyopathy and in case of raised ICT. Very important causes. Anyway, we'll be discussing more on this in the later lectures. But remember, hypertrophic cardiomyopathy and raised ICT can cause inverted T waves. So you just see the ECGs. So this is again a pediatric T wave. You can see you can see here inverted T waves. It's a normal finding. Persistent juvenile T wave pattern. Usually in this persistent juvenile T wave pattern, this is usually seen in the, of course, in the juvenile group, adolescent group, where you will get a asymmetrical shallow T wave inversion. Okay, and it is limited to V1 to V3. Only V1, V2, V3 will produce this T wave inversion, and it will be of less than 3 mm of depth. Then bundle branch blocks will get T inversion, as I have already told. Ventricular hypertrophy strain pattern will get pulmonary embolism, very important cause. Pulmonary embolism can cause T inversion. This T inversion may be associated with right bundle branch block. We'll be discussing pulmonary embolism more later, but as of now, remember that pulmonary embolism, because it is a sudden, it will produce a sudden strain on the right ventricle because pulmonary artery is blocked. So this right ventricular strain itself can produce T inversion. It may produce a right bundle branch block associated with T inversion, and sometimes it may only produce S1Q3 T3 pattern. This T3 means lead 3 will get an inverted T. Anyway, more on this we'll be discussing later. So as of now, remember pulmonary embolism can also cause a T inversion. Okay, S1Q3 T3 I have already told you. As you can see here, the prominent S in lead 1. Then in lead 3 you will get a prominent Q and T inversion. This is S1Q3 T3 pattern. This is very much characteristic finding in case of pulmonary embolism, but anyway, it is not specific and it is seen in only 10% of cases of pulmonary embolism. Hypertrophic cardiomyopathy, we'll be discussing more on this later. Hypertrophic cardiomyopathy will produce a inverted T wave, and I have already told you that it can also produce a prominent Q wave. A prominent R in V1 also, hypertrophic cardiomyopathy. Raised ICT also can cause T wave inversions like this. Now the next concept is biphasic T waves. Biphasic T waves are seen in ischemia and it can also be seen with hypokalemia. What is the difference in ischemia? The biphasic T wave that is seen in ischemia is, first of all, there will be a positive wave and then there will be negative wave. Because hypokalemia, first of all, there will be negative wave and then there will be positive wave. So biphasic T waves. Remember, biphasic T wave is seen in ischemia and hypokalemia. And this ischemia, we have to remember one syndrome that is known as Wellens syndrome. Yes. So this is Wellens syndrome. In Wellens syndrome, there are two patterns: Wellen pattern, pattern A or type 1 Wellens, Wellen pattern B or type 2 Wellens. What happens here? This is actually acute. This Wellen pattern is seen in acute LAD occlusion. Acute LAD occlusion. This produces two types of pattern. One is type A or type 1, another is type B or type 2. What happens in type 1? There will be there will be biphasic T wave. There is a biphasic T wave as I shown in the previous page. In type 2, or pattern B, there will be a symmetrical T wave inversion. Symmetrical T wave inversion in the precordial leads. Symmetrical T wave inversion in the precordial leads. Okay. So type A is biphasic pattern. Type A is inverted T pattern. So this is what you can see in valence pattern, and this valence pattern is seen in case of acute LED occlusion. Anyway, this also will be discussed in case of MI ECGs. Now coming to the next wave, U wave. U wave is the wave that follows the T wave. Okay, this follows T wave. Is usually maximum duration of U wave is 1 to 2 mm maximum. That is less than 25% of T wave. Ideally, it should be less than 25% of the T wave. Okay. And classically, this is described in case of hypokalemia. Okay, so this is the wave that follows the T wave. Maximum amplitude has to be 1 to 2 mm, less than 25% of the T wave, and classically described in hypokalemia. The mechanism behind U wave has been described in like there are so many hypotheses, but you can remember that mostly it is due to depolarization of papillary muscles or myocardial M cells. Anyway, the mechanism behind U wave is not important. What is important is in which condition we get a U wave. Okay, so features of normal U wave I have already told. So you can see here this is a small positive wave after the T wave. So normal U wave has to be maximum 1 to 2 mm or less than 25% of T wave. Less than 25% of T wave. Dominant U wave, that is more than 1 to 2 mm or 25% of the height of the T wave. It is seen in cases of hypokalemia, as I have already told you. Hypokalemia. You can also see in severe brady. See, there are so many other causes also, but I will not be telling. I will just be telling the important causes. Hypokalemia, severe brady, and digoxin poisoning also. Digoxin toxicity also you might get a prominent U wave. Okay, there are so many other causes. These are not the only causes, but as of now, just remember these causes. Okay, so that is something you can see there's a prominent U waves due to severe brady. These are the U waves as well hypokalemia. You can see the T wave flattening or inversion followed by U wave. These are the U waves. Okay. Then coming to the next wave, Osborn wave or the J wave. What is Osborn or J wave? This is nothing but a upward deflection. This is just a deflection at J point. At J point. What do you mean by J point? J point is nothing but the meeting point of QRS complex and the ST segment. Okay, so this is the meeting point of QRS complex, end of QRS and the start of ST segment. That is known as the J point. Whenever there is a deflection, upward deflection, it may produce a wave like this. This is known as the J wave or Osborn wave. J wave or Osborn wave. This is classically seen in hypothermia. This is classically seen in hypothermia, and also it can be seen in hypercalcemia. Okay, so I'll be writing here. So Osborn J waves are classically seen in hypothermia and hypercalcemia. Of course, there are some other causes, but I will not be discussing all those. Important ones are hypothermia and hypercalcemia. You get Osborn J wave. So the best place to see Osborn J wave is if you go to the ICUs where always the AC is on and many patients are hypothermic in ICU. You can see this wave. If they are connected to monitor, you can always appreciate these waves. So this is a case of hypothermia. You can see this small positive deflection is the Osborn J wave. Now coming to the delta wave. Delta wave is classically seen in WPW syndrome, and the concept behind that I have already discussed with you. The concept behind that I have already discussed that this WPW syndrome will have a triad. The first is PR, absence of PR segment, then there will be a small delta wave, and then there will be white QRS complex. So this is triad for WPW. It has type A and type B. Type A will behave similar to RBBB. So if you want to localize a WPW syndrome, regarding the localization of the accessory pathway, I have already told you that WPW, it can be type A, can be type A, or it can be type B, can be type B. Type A will behave similar to right bundle branch block. Type B will behave similar to left bundle branch block. In type A, the accessory pathway is on the left side. In type B, the accessory pathway is on the right side. Okay. So how will you, from the ECG, how will you find out which type of WPW this is? So first of all, you have to find the triad. If you get the triad, correct, that is the absence of PR, delta wave, and the white QRS, then that is from that comes from as WPW. The next thing you have to look at is the V1. If V1 is has negative or it has a dominant R, V1 has dominant R, as I have already told. If it has dominant R, that means this is similar to RBBB pattern. This is similar to RBB pattern. That means it is WPW type A. If you are getting a dominant S in V1, dominant S in V1, that means it is similar to LBBB pattern. LBBB pattern. So that is type B. Okay, so from the ECG itself, you can tell which type of WPW this is and where is the accessory pathway. Okay, so type A means accessory pathway is on the left side. Type B means accessory pathway on the right side. So delta wave is classically seen in WPW. Epsilon wave is the wave that follows the QRS complex. So it is a small positive deflection. It is a small positive deflection following the QRS. Okay. And this epsilon wave classically it is described in arrhythmogenic right ventricular dysplasia. Arrhythmogenic right ventricular dysplasia. So if you can see here, this is the epsilon wave. This is the epsilon wave. This is the epsilon wave, and these epsilon waves classically they are seen in V1, V2, and V3. V1, V2, and V3. They will also these ARB patients will also have associated right bundle branch block pattern. Anyway, I will not be discussing all those details here because again that will be discussed later. So as of now, just remember epsilon waves are classically seen in arrhythmogenic right ventricular dysplasia, and I have already told you previously that fountain leads are used to delineate the epsilon waves correctly. Okay, so this ends our discussion about the waves in the ECG. In the next session, we'll be discussing about the intervals and the segments. Thank you, everyone. That's all for now.